My next question is to MX Matthew. Based on your professional and lived experiences on how epistemic and structural injustices adversely impact mental health responses, how can we use bottom-up engagement approaches and an intersectional lens to better understand and address the root causes and management of health conditions?
Great, thank you for having me. And just like a job interview, there's 7 questions within that question. So yeah, thank you to WHO and Jack Fisher for driving my involvement, and good evening everyone from NAM, or the colonised name for Melbourne. So in the spirit of decolonial approaches, I'd also like to acknowledge the traditional owners of the land on which I stand and sit today, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders, past, present and emerging. Jack, could you post my full response in the comment as well, as I'm probably one of the people that's had to have their section cut because there's a lot to say and it's a really complicated question. I'd also like to acknowledge my own community, mental health community, and all the diverse locations for those of us that are attending. So who am I? I'm a mad person. I'm a manic depressive, and I'm very proud to be. I'm a queer, I'm a gender diverse person, non-binary. I'm also a critical social worker. I'm a critical peer worker. I'm a mad activist, a mad academic, and I instruct in mad studies in critical mental health at university level. I'm a mad researcher or peer researcher. I'm a child who's lost a parent to suicide. I'm also a suicide survivor myself. I've been a young carer to my younger siblings and a witnesser to their suicidal experiences. I'm also a child that's previously been in out-of-home care, in foster care. I've lost my grandparents to stigma and discrimination, shame and saneism, and I grew up in material deprivation and poverty and went to one of the lowest socioeconomic public schools in my state and province after my mother passed away and my grandparents removed themselves. I grew up in abuse, violence, family violence, alcohol misuse, and intergenerational mental health issues. So that frames where I'm coming from. The reality of the mental health system is that it's colonised, it's ableist, it's sanist, it's patriarchal, and it's set within a neoliberal, corporatised economy that monetises our distress, our experiences of trauma, our neurodivergence, and our neurodifferences beyond the societal norms, which again are ableist and sanist by design. Us mad and neurodivergent folk are blamed within a capitalist, individualist global industrial complex, which is predominantly through the biopsychiatric model, which seeks to monetize us. They're depressed, they're suicidal, they're bipolar, they've got schizophrenia, they have a personality disorder. When actually the reality for 80–90% of us, we just exist in an unjust, and we survive in an unjust, ableist, sanist, capitalist, colonialist, patriarchal society with social, cultural, spiritual and structural conditions that enable us to express ourselves in ways that in turn result in violence of the system. We see this in high-income countries where there's a colonisation of psychiatric services in the global south as well. And I come from obviously a high-income country in Australia, where we see no real changes of growing mental health issues in political economies, which create an us and them and actually widen the class gap. And we know that mental health and the class gap and poverty all have an interconnection, inequity, poverty, etc. So an unequal world results in personal distress as the result of structural injustice. And by structural, I mean our intersectional identities and the privilege and oppression afforded as a result of power. I also mean the political, economic and material determinants which shape the politics of our experience. Structural injustice impacts how we express our iatrogenic distress and trauma from the system, from the services we use and the institutions that shape us. In summary, we need a whole of member state, whole of government, whole society response, which includes sustainable political economic models and systems which move away from hierarchy to inclusivity and partnership. We need systems to address power and injustice. We need a retraining of mental health professionals led by us with lived and living experience in curriculum design, in teaching and in community at all levels in research where we co-construct. Furthermore, we need psychiatry and psych sciences to ally and share power in sensitive and epistemically privileging ways to address that epistemic injustice where medicine is the most privileged knowledge base in the system. And the root cause, of course, of our issues, which actually are often social, cultural, spiritual and structural, which then in turn impact the individual, the psychological and the biological determinants. We need to address the root cause analysis of these issues. We don't eat our cereal with a fork, we use a spoon. So why do we use a predominant medical tool to understand social, cultural, spiritual, and structural causation to people's experiences? The system makes no sense. So finally, because you're all probably waiting for me to wrap up, we need empathy, we need love, we need compassion, we need to be culturally led, we need to be community driven. Doesn't matter where you are in the world, we need to have socially just based communities that talk about power and how to share power. This involves intersectionality, it involves lived and living experience leadership in all solutions, then with the allyship of professionals and community. Thank you.
Thank you very much for provocative and much needed comments, Matthew.